Thank you, Kathy. It's a pleasure to be here, and I thank you all for attending today. So I'm going to cover the developments at San Antonio that involve HER2 and triple negative, and also some of the biological drugs being used in ER-positive cancers. So I'll start off talking about a very important pathway that you've heard a lot about, the Pi3 Kinase Mtor pathway. This is a pathway that's used by many growth factor receptors. It's also used by the cell when it encounters nutrition. For example, serum-starved cells that are given serum will grow. This is something that cells are supposed to do. And so this pathway is often hijacked in cancer. There are a variety of aberrations that can enhance this pathway. For example, mutations in the receptor tyrosine kinase that can initiate this pathway. We know HER2 can be amplified, and there's other mutations in other growth factor receptors. There can be activating mutations in Pi3 kinase, in AKT, and there can be loss of P10, which actually is a phosphatase that dampens this pathway. So all of these can be targeted by a whole new generation of drugs. One of these, of course, is approved, everolimus. A couple of Pi3 kinase inhibitors are now approved for hematologic malignancies. Many others are in development. Some are specific to the catalytic subunit of Pi3 kinase. And this is important because in breast cancer, there are common mutations in the PIK3CA gene, which is the alpha catalytic subunit that can activate this enzyme. Whereas in other cancers, it may be the beta, for example, in hematologic malignancies. And this comes into play as I discuss some of the findings from these drugs. I'll first focus on mTOR inhibition. Of course, everolimus is approved in hormone receptor positive cancer in combination with exemestane. However, there's no randomized data with fulvestrant. And of course, we have many patients who are going on to fulvestrant, or based on the data that Hope showed you from the Falcon trial, this may eventually become first-line therapy. So how everolimus functions in this combination is important, and this was asked by a precog study. It was a smallish study, and it randomized patients to a 48-week induction phase where they were blinded, and then they were unblinded and could continue as long as there was no progression or significant toxicities. And this study, in fact, did show a fairly wide difference, similar in the hazard ratio as what was seen in Bolero 2, which was also in the second-line therapy in combination with exemestane, a hazard rate of 0.6. The toxicities were as expected. There were more overall toxicities and mucositis and stomatitis, although less than 10% that was grade 3. And these patients did not receive steroid mouthwash prophylaxis, which has recently been shown to actually be quite effective when used in the early phases of treatment with everolimus in preventing mucositis. No difference in survival. Of course, this study was not powered for survival. And also, I'll remind you that in the Bolero 2 study, a much larger study, there was no difference in survival, even though there were a reasonable number of death events to analyze in the final analysis. Let me now move on to Pi3 kinase inhibitors. This is a study with a pan-kinase inhibitor. It inhibits all of the catalytic subunits, so is less specific. This is a BKM 120, buparlacilib, and this was in patients who had been pretreated hormone receptor positive breast cancer, and they all had to have progressed with therapy on an mTOR inhibitor. Patients were randomized 2-to-1 to receive fulvestrant with buparlacilib or placebo with fulvestrant. And the study in the overall population, unselected for Pi3 kinase mutations, was positive. You can see that the times to progression are short, as you might expect in this population, but it was significantly prolonged. Now, whether or not this is clinically significant, I think, is a matter of debate. I think that what's important is to know that we see a signal, and then, of course, might try to use these drugs in other situations, either in first line or, if safe enough, maybe even bring them into adjuvant therapy. So I think this is a step forward, although it's in a difficult population to treat. And the subset analysis does not show any clear responses across these different clinical categories. But of course, the big question is there a difference based on the Pi3 kinase mutation status? About 30 to 40% of hormone receptor positive HER2 negative cancers actually have activating mutations in the PIK3CA catalytic subunit. They tend to cluster in hotspots that activate the enzyme, the kinase activity. And so the division here by the mutation-bearing cases, which is about a third, showed the benefit was mostly in this subgroup and not in the wild-type subgroup. Now, interestingly, they obtained liquid biopsies. You heard from Suzanne the importance of sampling the tumor, whether it's with a biopsy of the tumor or DNA that is shed into the blood or in membrane components of the blood. In this study, they were able to pick them up both in the tumor and in the blood, but they didn't always correlate with each other. There were some that were only in the blood, some only in the tumor. I think this is just a sampling issue. We know that when we do biopsies of tissues, you get a HER2 positive in one, a HER2 negative in the other. It's an issue with sampling because the tumors are heterogeneous, and also you may simply not have a sufficient specimen. So we're going to need to get more refined technologies to bring the concordance to match a little bit better, and a lot of this work is underway. I personally feel that liquid biopsies will be very informative in the future. They may not completely substitute for tissue biopsies, but this was nice that they provided this information in this relatively small study. The side effect profile is important to mention with these drugs. I'd say the most common side effect is asthenia, fatigue. There are some transaminases, and this drug crosses the blood-brain barrier. And remember, the PIK3CA and this whole pathway is active in many normal cells as well, and depression is a big part of the side effect profile. In fact, there were 3 cases of suicide attempt in this trial. Another Pi3 kinase inhibitor, telesilib, is a selective inhibitor. It's not truly an alpha-specific. It's more what we call a beta-sparing Pi3 kinase inhibitor. And this was tested along with fulvestrant, again, in hormone receptor positive, HER2 negative patients. And again, responses were seen. This was a small early phase study, and randomized trials are going to follow. About a third of the patients exhibited a response. Now let me move to HER2 therapy. A couple of important developments. One of them is this exploration of the combination of hormonal therapy with HER2. We typically do that, of course, in the adjuvant setting, and more and more now in the metastatic setting when patients are off the chemotherapy phase. We're adding hormonal therapies to maintenance antibody treatment. And of course, with kinase inhibitors, with lapatinib, we also have data in combination. So this was a study that was formally designed not so much to look at the combination of hormonal therapy, but really to look at the addition of pertuzumab to trastuzumab, but in the context of aromatase inhibitor therapy. And this study showed, as expected, that the times to progression were significantly prolonged with the addition of pertuzumab. It did not specifically answer the question of plus or minus hormonal therapy. We do have retrospective data, however, that supports this quite nicely. A study of 1,000 patients with HER2 positive cancer, this was a prospective registry study, has shown that the addition of hormonal therapy in that cohort, non-randomized, mind you, was associated with a significantly improved outcomes. And so now we are commonly using hormonal therapy. This study shows that pertuzumab with hormonal therapy does provide the expected benefit similar to what was seen in Cleopatra. And again, no difference in the subgroups stratified by the different clinical subtypes. I'll also add that in the neoadjuvant setting, there has been a demonstration of testing of HER2 therapy with or without hormonal therapy, showing a slight advantage, but not really statistically significant. But of course, in the hormone receptor positive cancers, we tend not to see increases in PCR. Now, let me move on to HER2 mutations. This is a very interesting finding. We've known about HER2 mutations for quite some time. In fact, they were originally described in lung cancers, but very rarely in breast cancers. And it really wasn't until we started doing large-scale sequencing from projects like the MetaBrick and the Cancer Genome Atlas that we started picking these up. And they're rare. They're 2 to 3% of cases in the TCGA, and of course many more now have been gathered. And these are among patients that are HER2 negative by standard assays. So the HER2 gene is not amplified, it's not overexpressed. But it can harbor a mutation, particularly they're clustered in the kinase domain, that autonomously turns the HER2 receptor on. So it's really blind to anything else it sees. Now, there are some mutations in the ligand binding domain that act differently, although some also activate the kinase domain. And what we're finding out is that most of our data on mutations comes from untreated patients. And in fact, this is why it was so hard to discern estrogen receptor mutations that you've heard about in the previous lectures, because they tend to arise after exposure to aromatase inhibitors specifically, interestingly, not to tamoxifen. And as we started sequencing tumors after treatment, they became more evident. Similarly, with HER2, we're finding that in patients that recur after exposure to trastuzumab, we're seeing this at a higher rate. But we also see them at baseline. So the big question is, can we use kinase inhibitors to treat patients with HER2 negative assays by conventional means, but that are known to have the mutation by sequencing? So this was a study that was confined to HER2 mutations. It also included a few HER3 mutations. And you can see that sorry, let me get to the data. This is data from a large study, a medium-sized study, I should say, that enrolled patients with a variety of cancers. And this report is focusing on the HER2 mutations that were found in patients with breast cancer. 2 cohorts, one that was treated with the HER2 kinase inhibitor neratinib as monotherapy, and one in combination with fulvestrant. Neratinib is a potent dual kinase inhibitor that inhibits HER1, EGFR, and HER2, both. And so you tend to get a lot of the toxicities, mostly due to the EGFR1 binding, skin rash, and particularly diarrhea, which is a significant toxicity with this drug. This study actually did show responses. About a third of patients receiving neratinib monotherapy, and about a half of the patients in combination with fulvestrant. Here are the waterfall plots that show the responses in the monotherapy cohort and in the fulvestrant cohort. And this is an example of a patient that responded, the PET scan showing responses throughout, and the CT portion showing responses in the liver. And responses have also been seen in other tumor types that harbor HER2 mutations. These are also seen in bladder cancer, lung cancer, colorectal cancer. And some of these also respond to trastuzumab, although the responses to trastuzumab are less because the kinase domain is turned on constitutively. However, in the ligand binding domain mutants, which are much less common, we have seen at our institution some responses to trastuzumab or trastuzumab plus pertuzumab. And for those of you that are participating in NCI Match, there is a drug for HER2 mutations. It's not neratinib, but it's a drug, afatinib, which is used in lung cancer, also a dual HER1, HER2 kinase inhibitor. Now, I had mentioned some of the limitations with the HER1, HER2 dual kinase inhibitors, primarily the toxicities. It's been very difficult to design HER2-specific kinase inhibitors. This is an example of one that has specificity for HER2, ONT-380, tucatinib. And it's an oral bioavailable drug that is selective for HER2. It does have some, but very minor EGFR, and so it does not have the toxicities like skin rash and diarrhea. So this was a study that took patients with HER2-positive metastatic breast cancer that had progressed with prior therapy that had to include trastuzumab, taxane, and TDM1. They did include patients with CNS disease, and prior pertuzumab and lapatinib was permitted. This study was a phase 1b study with escalating doses, and they only tested it in combination with either capecitabine or in combination with trastuzumab, and then they did a cohort with the triplet with capecitabine, trastuzumab, and tucatinib. So this is a report from that study. In terms of safety, they did not see the kinds of problems with GI toxicity seen with neratinib or with lapatinib. No cardiac failures, again, in this small study. We obviously are going to need larger studies. The safety profile really did not seem very different from what you might expect with capecitabine and trastuzumab. The best responses are shown here. So in the doublet cohorts, either with capecitabine or with trastuzumab, they saw a high rate of response, 83, 40% response, and then in the triplet, 61%. So very early data. The numbers are small. This is still a phase 1b study. And larger studies are now in progress. There's a randomized study, capecitabine, trastuzumab, plus or minus tucatinib, for patients who have progressed on standard therapies, with the exception of capecitabine, of course, since that's the chemotherapy backbone. And that study is ongoing. These are the waterfall plots from these cohorts. These are in the doublet cohorts with trastuzumab and with tucatinib. And patients with CNS were allowed on this study. So you can see, I'll show you a summary of those patients separately. And then this is with the triplet cohort. You can see that the responses were quite high in this group. And this is the swimmer's plot to show you the duration of responses. You can see that several patients went all the way up to close to a year, and then in the triplet, a good number of patients are out past a year, generally in patients who've exhibited a response. Now, specifically in the group with brain metastases, and there's a lot of interest, as you know, with smaller molecules that cross the blood-brain barrier. Just by way of background, there's always been a sense that perhaps with large drugs like antibodies that don't cross the intact blood-brain barrier, might there be more chance of developing brain metastases among these patients, because no doubt HER2-targeted therapies are very good at prolonging responses in the viscera, and these patients are living longer. So if you go back to the adjuvant trials and ask the question, are you seeing more patients develop brain metastases? None of the single trials have shown that, but if you do a meta-analysis, you do find a slightly higher rate of brain metastases. And then if you look at the metastatic trials, similarly, you see a higher number of patients progressing in the brain, but again, these patients are living longer. So the question is, can capecitabine, which we know crosses the blood-brain barrier, and lapatinib work better? We do know that there's a minor amount of activity with these drugs, but if you look at the data with trastuzumab and pertuzumab, those also cross the blood-brain barrier when there is tumor involvement. So we don't really know the best. There is no preferred therapy for brain metastases. Obviously, we use local therapy, but when patients progress after local therapy, there's a need for these patients. So I was very impressed by the PFS and particularly the responses that were seen in the CNS with tucatinib, and this is with combination. Now, there are other studies of tucatinib that I'm going to report. This was a phase 1 study reported by Otto Metzger and the group at the Farber, showing specifically responses in the CNS as well, in this case with the drug alone. So without any other drugs, they saw it in 3 of 41 patients. Let me now move to triple-negative cancers. I'm going to focus first on PARP inhibitor trials that are focused on patients that carry BRCA1 and 2 mutations. Of course, these aren't only triple-negative. We know that, especially for BRCA2, the proportion of receptor subtypes is about similar as it is in unaffected breast cancers. So this was a study following up on responses that have been reported with several PARP inhibitors in patients with BRCA mutated cancers. This is a phase 2 randomized study. There's also a phase 3 larger study ongoing, testing the combination of carboplatin and paclitaxel with veliparib or with placebo. And then there was another arm based on pilot data showing response with temozolomide, which of course is a nitrosourea with good blood-brain barrier penetration. Veliparib is one of the PARP inhibitors that is a little more easily combined with chemotherapy. Some of the other ones have a variety of toxicities in combination with chemotherapy, although there are studies looking at other PARP inhibitors as well. So this study reported early results, first with toxicity. Significant toxicities with veliparib have been seen, particularly GI and hematologic toxicities, although in this study, the overall rate of grade 3-4 toxicities was not different. However, progression-free survival did not meet its endpoint. There was no statistically significant difference in the hazard rate, close to 0.8, which did not meet the level of significance as shown here. My understanding is that the phase 3 study is still going to continue. Obviously, it's going to have more power than this one, but this was a little bit of a disappointment, I would say. Now, there's another drug that some of you may be familiar with that also has shown activity in platinum-refractory ovarian cancers and also in cancers that exhibit DNA repair abnormalities. This is a product that was derived from marine microorganisms. And there's been an effort to look at a variety of microorganisms, either from marine or from the soil. As you know, many of our anti-neoplastic drugs come from microorganisms. And the question is, why would microorganisms make compounds that might be helpful with cancer? Well, there's a couple of reasons. One is that microorganisms do not have a classical immune system, so they have to handle invaders, particularly viruses and bacteria, with compounds that they synthesize. So obviously a lot of our antibiotics come from molds and single cell or a small number of cell organisms that don't have immune systems. But what about anti-cancer agents? Why would these microorganisms contain these? Well, remember, many microorganisms are able to grow in normal cells by inactivating the same defense mechanisms that protect us against cancer. For example, the papillomavirus inactivates P53 and retinoblastoma. These are two important checkpoints on cell division that are blocked when there is DNA assault on the DNA, for example. So it's critical for us to have these checkpoints to avoid cancer. We know that patients that have inherited mutations of retinoblastoma and P53 develop cancer at a very high rate. So marine organisms and other microorganisms that have evolved over the eons to successfully propagate not only contain compounds that could be effective against bacterial and viral infections, but also against the processes that damage our checkpoints that can be cancer-causing. So screening, large-scale screening of these compounds is ongoing, and this company from Spain, PharmaMar, has specialized in looking at this. So one of these drugs, which is an analog of trabectedin, which is approved in sarcomas, lurbinectedin, binds the minor group of DNA, and particularly to GC-rich areas of the genome. And it seems to selectively inhibit cells that have DNA damage repair defects. So, of course, BRCA cells that have BRCA knocked out, which, of course, governs DNA double-strand repair, would be obvious targets. It also has some effects on the microenvironment that aren't well understood, and it's not clear. One of the challenges of studying these complex molecules that are derived biologically is that they are multifactorial. They have a lot of other effects that we don't fully understand. But nevertheless, its effect on DNA repair deficient cells and especially platinum-resistant tumors guided the examination of this study, which was specifically confined to patients with BRCA1 or 2 mutations. And this data was actually presented at ESMO, so I'm cheating a little bit, but Hope opened the door to bring in ESMO abstracts, so I figured I'd follow. And I furiously created this slide while Hope was talking, and thanks to the projectionist for getting them in. But this was really impressive, a 40% response. These are patients that had been pretreated, and the current amendment now includes patients pretreated with PARP inhibitors, and a larger phase 3 study is now planned for patients with BRCA1 or 2 mutations. So we expect to see more from this. Let me now move to other triple-negative strategies. This is an immunoconjugate, and I must say that in addition to small molecule kinase inhibitors, an area that is growing very rapidly in the pharmacology area is immunoconjugates. And of course, immunotherapy now is a hot area too. But immunoconjugates can be very selective. And what you typically do is you bind a very toxic moiety that could not be given alone to either a peptide or an antibody that recognizes a cancer-specific antigen that's expressed on the surface. And the key to success is this longer ether linkage, because it allows the toxin to be disassociated when it is taken up by the cell. So the lysosomal environment that has a different pH and so on and so forth will allow the toxin to be broken off in the cell with minimal systemic toxicities. Now, they're not all successful. In fact, immunoconjugates have been around for 20 or 30 years, but it really wasn't until the linker technology got better that we're seeing successes, like TDM1, for example, for HER2-positive breast cancer. So this one binds a commonly expressed antigen on triple-negative TROP2, and it delivers SN38, which is the active metabolite of irinotecan. This trial enrolled 69 patients with triple-negative breast cancer. They had to have relapsed to at least one standard therapy. However, the median number of therapies on this trial was 5. This study generated a response rate of 30% with durations of responses of up to 9 months. 3 are ongoing now, out quite far. So this is very exciting to see these 1-year survivals or greater. Of course, we're seeing some of these with immunotherapy as well, but we anxiously await further therapy and larger scale, further follow-up in larger scale trials with these immunoconjugates. There's a whole host of immunoconjugates now being developed, and also we have a program at MD Anderson where we're trying to develop personalized antibody-dependent conjugates to toxins based on what that particular tumor expresses, or to create an off-the-shelf suite of these drugs that can be customized. I will end my talk with some of the newer drugs being used specifically in CNS metastasis. ANG 1005 is a paclitaxel conjugated to a soluble receptor that allows it to cross the blood-brain barrier, a lipophilic receptor, I should say. This drug was tested in patients with previously treated brain metastases. They all had had prior surgical resection and radiation therapy. It allowed KPS of 70, which is not common for many trials, but many of these patients have compromised performance status. And responses were seen in 16% of the overall population. Similar to what we're seeing with in HER2 positive, which of course is much easier to treat, but keep in mind these are all HER2 negative cases, so much more difficult to control. And there also was an extracranial response of 9%. Keep in mind this is a paclitaxel-bound drug, so it does have systemic. Now, I will end with the whole idea of genomically targeted therapy. How many of you all have sent a tumor tissue for next-gen sequencing for breast? Okay, so many of you have, and I think that number is going to grow. Right now, really, the only clinically indicated reason to do this is to select patients for clinical trials. This was a trial run by the French group, SAPHIR-2, to look at how successful it is in a large multi-center study to identify patients and to treat them on study. So patients, 1,400 patients were screened. These are all patients who had progressed on chemotherapy. They had tumors sequenced, and the targetable drugs were those with targetable lesions that were amenable to small molecule or other inhibitors were randomized to either standard treatment or the targeted therapy, and those that didn't have a target were actually randomized to durvalumab, a checkpoint inhibitor, or standard therapy. So really clever design. So if you don't have a genomic lesion, let's put you on immunotherapy. And so they have screened 457 patients. This was an interim analysis presented by the group, and it was feasible. They were able to identify targetable alterations in 2/3 of the patients. They did have some failures due to low cellularity. And these are the alterations that were used for shows how everybody was allocated. So BRCA mutations got olaparib, so on and so forth. Those that had alterations in RAS and that pathway on MEK inhibitors. So they were able to at least demonstrate feasibility, and here are how the targets broke down according to what was presented at their molecular tumor board. And I will end with the fact that this is the universal sign of money. Are we going to be able to afford these combination therapies with immunotherapy? And for those of you who haven't seen the San Antonio presentation by Peter Bosch, I highly suggest you see it online. He really gave a cogent argument as to how we cannot sustain this and how we as physicians, but really the larger community, can rein in the cost so that we're able to treat our patients more affordably going forward. So I will end with that. Thank you very much for your attention.